Recording in progress.
All right. Now, today is about connecting what you've learned this week, what you've read, what you've heard or saw, and make sure it makes sense before we kind of bring it all together. Because next week is midterms, and I want to make sure that you guys are confident going into midterms. Okay. So, we start off with this very first slide. Take a look at what's happening visually. Okay. So, just you're looking. On one side, how microbes live and grow. In the middle, how they travel and invade. And then on the other side, we're coming over here to how they change and adapt. You'll notice that there's not independent facts. They're like most of micro steps in the process. If you only understood how microbes grow, but not how they invade or how they adapt, where would your understanding break down clinically? Now, I want you to just think about that. That gap is where infections win. When a patient develops an infection, it doesn't happen randomly. You have the organism, how it survives, how it finds a pathway, how it adapts to pressure, including antibiotics and the immune response. That's why microbiology is about patterns. Okay. Now, we're getting closer to the midterms. So I know that it can be daunting with how many chapters and how many organisms and different things go through. But I want you to not separate, okay, well, this is chapter 6 versus chapter 7 and chapter 9 separately. I want you to start asking yourself, how does growth support invasion? So you'll notice how they all connect. How does invasion create pressure to adapt? And how does adaptation change treatment and prevention? This is how we get into that deep understanding. Now, if you had to explain an infection to a patient, or let's even say one of your peers, let's say that you guys are studying together, would listing facts help or really kind of explaining what's going on in more of a story faction? Story fact. And the reason I ask that is because now, as you guys can see for a surgical tech, our program, it shows how microbiology tells stories, how different chapters connect and kind of build onto each other. And it doesn't stop here. Once you get to module 3, you're going to see some of these same concepts brought from micro to theory 2. And even in pharmacology, there's going to be different little things that you'll be like, aha, I did hear that. So this is why this particular medication or antibiotic is given from something that we learned in micro. Okay. Now, you're going to encounter a lot of these microbes. Sterile technique, I mentioned, infection prevention. And the biggest thing for us being that we're the patient advocate, we look at patient outcomes. And that's why we start to think of these chapters in microbiology in systems. Microbes succeed when we think in pieces. We succeed when we think in patterns. Okay, now the environment is everything. If you understand where a microbe thrives, you can often kind of predict where it comes from and how it actually spreads. Look at the left side first. Okay, pretend like you don't see the guiding question over here. Microbes have preferences: temperature, oxygen levels, pH. Those preferences are not random. That's how they survive, that's their requirements for survival. If a microbe prefers moisture and, let's say, moderate temperature, would you expect to find it in a dry metal air or in fluids? This is how we start thinking and reasoning in microbiology. Exactly. Now we come to the right side. When you understand growth requirements, reservoirs actually start to make sense. You think of water droplets, soil, medical instruments. That's why we talk about this in the first 2 weeks in ST 300. Microbes don't choose these places, it's like they're matched to them. Okay. Now, based on environment alone, which of these would you predict is the highest risk reservoir in a surgical setting? And keep in mind, there's no wrong or right answer. It's just kind of seeing where your mind's at, right? What matters is how you got to that, okay? But here's the key connection. If a microbe survives well in moisture, how is it likely to travel? Contact, droplets, or instruments? So I'll ask that again. If a microbe survives well in moisture, hint, hint, how is it likely to travel? Contact, droplets, or instruments? There we go. Growth requirements shape transmission routes, and you guys are all thinking on that right path. Now, as STs, we're not just cleaning our instruments, we are interrupting environmental matches, like trying to break them up. Okay. We change temperature exposure, we change oxygen availability, we change moisture levels. That's how infection prevention actually works on the microbiological level. Microbes do not spread randomly. They spread when the environment lets them win. Now, the key thing here is that microbes don't just live in environments, they change to survive them. A microbe doesn't need dozens and dozens of changes to gain an advantage. Sometimes one genetic mutation is unfortunately enough. So let's walk through these images together. Okay. We start on the left. Biofilm formation, protection, and persistence. Okay. In the center, there's that genetic change. There's a switch. And then on the right, we have the immune evasion. Now they're trying to survive inside of the host. This isn't three topics, believe it or not. It's one survival strategy broken up so that we can kind of follow it and see it. If a bacterium becomes harder to kill, we think about what it actually means. More growth, more protection, it gets better at hiding. That instinct is exactly what microbiologists use when they're trying to figure out how are we going to combat this bacterium versus another. Now, let's take the guiding question. Okay. If a bacterium undergoes a single genetic mutation, how could that help it form a biofilm? Now, we have biofilm, it's everywhere. One of the most common areas of biofilm is on our teeth. Okay. And we brush it off all the time. Now, we think about one small thing changing, increases surface adhesion, it enhances matrix production, it improves communication with neighboring cells. That's how it helps that biofilm stay. Now we're bringing it all into a logical sequence. In one short phrase, based on what I just mentioned, what does a biofilm give a bacterium? Think of Superman and his cape. I don't know if that's a good example. Um, a safe environment, shelter. Biofilm gives that bacterium almost like they're have a superpower now. Okay, it's a defense. Um, it makes it more persistent, gives it protection. And I love what David said. It's a safe environment. The bacterium doesn't have to worry. They got their shield up. Okay. Biofilm is one of the hardest things to break down. Now let's take that same mutation and think about the immune system. If a bacterium is harder to recognize or reach, how effective is the host's defense? Biofilm and immune evasion often work together. And David's correct, it's not very effective. I want you to think about this. If bacterium survives the immune response, so our immune is out there trying to punch it, beat it down, and it has up its shield. What does that mean for infection duration? Does it become acute or chronic? I have one person answering right now, and on point. That distinction matters clinically. Okay. Now, realistically, as STs, we don't see the genes, but we absolutely see the results. Patients are going to come to you on your table with infections. You may have devices that are hard to sterilize, infections that don't respond as expected. And so now they're coming back to us for something else to try to help them. And those outcomes often trace back to adaptation. One small genetic change can completely change the outcome of an infection. Are you guys with me so far? Does that make sense? Okay. Now, let's walk through what you're seeing. One cell, you have many cells, and then you have dense coordinated population. This isn't just growth, it's organization. If one bacterium enters a surgical site, is that patient immediately infected? Yes or no? And this is important because the why matters more. Okay? The guiding question names three concepts that work together. You have generation time, horizontal gene transfer, and virulence factors. But believe it or not, these are not separate facts. They're an escalation system. We start with generation time. If bacteria divide every, let's say, 20 to 30 minutes, how quickly does one cell become thousands? Speed is the very first advantage microbes have. If a bacteria multiplies quickly, we think about what happens to the margins of error in our sterile technique. Does it shrink or grow? Well, it's going to shrink. That's why timing matters. Now, the horizontal gene transfer. This is where bacteria do not wait for generations. They share advantages. One cell gains resistance, another gains virulence, and suddenly the whole population of bacteria is benefiting and having a party. Is this more like individual survival, or do you think it's teamwork with these little sneaky bacteria? What do you guys think? That's right. And that distinction is so important. It is. It's teamwork. Now, the virulence factor. Haha. These determine how much damage is actually going to occur, how easily the microbes spread, and how hard it is for the host to be able to control the infection. This is where a localized issue becomes systemic. So we put it all together: fast reproduction, shared genetic advantages, increased ability to harm and evade. That is how a minor contamination can escalate into a severe body wide infection. Again, we don't usually see the end stage. We work at the earliest points where preventing escalation is actually still possible. Infection isn't about, like, okay, someone made a mistake. It's about how quickly small problems are allowed to grow. Now, I want you to treat this slide like a real clinical situation. We have a facultative anaerobe in a deep, poorly oxygenated wound. This can happen. You may have a patient coming in with this. Nothing about this is going to be set up or accidental. Okay? Let's start with what we already know. A facultative anaerobe can survive with or without oxygen. True or false? That's correct. So, in a wound where oxygen is limited, does the population in this case struggle or adapt? Exactly. Unfortunately, in this environment, we're talking about the prediction comes straight from metabolic logic, like we already know. In a deep, poorly oxygenated wound, a facultative anaerobe does not just survive, it often thrives, which is really bad for our patients. This is metabolic flexibility in action real time. But we're going to add one more variable. The microbe acquires a new toxin gene through transduction from a bacteriophage. One event, one gene. Now, growth may stay the same, but harm has just increased dramatically. That single genetic event can increase tissue damage, intensify inflammation, overwhelm the host's defense, and then escalate to a localized infection into a systemic threat. I want you to think of necrotizing fasciitis. Okay. In those patients, we have to debride all the way until we get to healthy tissue. Sometimes that's all the way to the bone. Okay. So just keep that in mind. This is why genetics matters more on a clinical side. Now, you may never know exactly which gene a microbe carries, but you do control the wound environment, oxygen exposure, how you're handling the tissue when you're in the case scrubbed in, time to intervene. Okay? Those particular factors determine whether microbes get a chance to escalate or um or not really. Okay? That is big. Hold on. I see a question. I went too fast. Okay. If anaerobic bacteria is usually causes purulent DNCs, does third intention wound healing require a wound vac placement? That is an excellent question. Now, anaerobic infections are commonly associated with exactly what you're saying. That purulent, so if you guys don't know what that purulent is, it's that thick, foul smelling drainage. Okay. You'll have devitalized tissue, so there's tissue that's dying. You already have low oxygen. A lot of times in like our deeper wounds or abscesses, and this is just for those who may not know, we do get those particular cases. But purulence does not automatically mean we need that advanced therapy. Now, a lot of times we will do a wound vac after certain cases, but what it does do is it singles infection, um not necessarily the treatment choice, because that's really going to depend on the surgeon. We had real time a plastic surgeon. We had a case where we were constantly bringing the patient back. The patient did not get wound vac just based on that particular surgeon. But then I had another patient where we definitely did the wound vac. Okay. Now, third intention wound healing, just for you guys, is where we kind of leave the wound open because of, whatever. It could be contamination, it could be infection, or maybe just swelling or edema. And then we'll go back in and we'll close it later. Now, here's the key for these particular cases. A lot of times they assign you. So, like, for example, I work Monday, Wednesday, Thursday evenings. And so if that patient was scheduled for like a Monday, then that team, usually me and other people that did the first case, they try to keep it for consistency. But the cases um, are closed later once the infection is actually controlled, or maybe they'll see that there's less drainage. And in best case scenario, the tissue viability actually improves. Okay. So, no, not automatic. I said all that to say no, not automatic. Does that make sense? Closing during granulation tissue. Explain a little bit more what you mean. Okay. Okay. All right, cool. Now, if you guys had more questions, I can try to find like different videos and stuff so you can kind of see as well how that works, because then it'll kind of help bring it together. Granted, we do cover a lot of this in the later ends of module 3, but like I said, it all connects together. So I love questions like that. Keep bringing them on. Now, the other thing that we do talk about in the first weeks in module 3 is sterilization. And this is important because if sterilization can't fully penetrate which microbes survive, the outer ones, or the inner ones, we're trying to figure it out. Like the ones that are buried the deepest would be the hardest ones. Okay. You will also hear us say a lot that perimeters for sterilization have been met, which means we had the right temperature, we had the right air pressure, we had the right, machine for that instrument. We never say or confirm sterilization until we have confirmed that a biological test was done and those particular spores were killed. Okay. But we also have to talk about the immune system. Phagocytic cells are very effective when they can reach their target. But biofilm, remember, biofilm is very sticky, it's very thick, it's not going to make it easy. It hides surface markers, it limits immune cell access, it reduces the recognition. So even though the immune system can be present, it can still lose because the biofilm has given the bacteriophage or the bacterium superpowers like invisibility. Okay. If both sterilization and immunization cells are blocked, think about what that means for infection persistence. So, a lot of times you'll hear that biofilm is associated And those infections are often chronic. And this is why. The key thing is we're one of the last barriers before biofilm can ever form. So we're very, very vigilant. We're very attention to detail when it comes to protecting our patients. So we think about how instruments are cleaned, inspected, handled, and actually how they are stored. This determines whether microbes ever get the chance to kind of go in and build their invisibility fortress. Now to the slide that was trying to go earlier. We look at lysogeny. It is the most common missed idea, um, misconcept that I see sometimes on your midterm and sometimes even in this week. And it's missed because it's usually taught like in isolation, like by itself, right? So I'm trying to do that differently. So let's walk through what we're seeing together. On the left, we have bacteriophage that integrates its DNA into a bacterium. In the middle, the bacterium continues to kind of live and divide and do its thing. On the right side, the same bacterium is now going in and causing more damage. This is kind of like cause and effect, okay? If viral DNA produces part of a bacterium's chromosome, we have to think, does that DNA disappear when the bacterium divides? What do you guys think? But just by looking at the image, do you think that original bacterium was like, peace out, I'm gone? Or is it still there? I see an answer. It is. It's still there. What it did is it copied and was like, haha, I'm going to copy myself and I'm going to stay here and pass it on. Okay. That means something very important. That bacterium did not just survive, it got new traits. It was like, I'm about to be an Avenger and I'm going to get some extra superpowers. Okay. Now, here is the key connection with lysogeny and transmission. If this bacterium is transmitted through contact, surfaces, or even our instruments, it's not just being moved, it's delivering new genetic instructions into our patients. But what do we see? We see unexpected severity. Infections that, wait a minute, this infection is getting escalated really fast. Outcomes that don't really match the original contamination. That's what we see. And the reason is lysogeny. Okay. Transmission isn't just about movement, it's about what moves with it. Now, again, this course does have some really cool clinical significant topics. So I want you to imagine this. You're in the middle of a procedure and the surgeon identifies I have a possible infection. At that moment, believe it or not, microbiology stops being a chapter and now it's like, okay, surgeon has a decision point that has to be done. We also have to think what matters more, speed, accuracy, or communication, or all three. I like that. Whatever doesn't kill you makes you stronger. Now, in this instant, that's right, all three. That's big. Okay. We need speed, we got to be accurate, and we all have to be on the same page. When a surgeon requests a, let's say, culture and sensitivity, for example, the goal isn't just to send a sample. The goal is to get reliable information that will guide treatment. We'll talk about that in Module 3 on how we even gather those specimens. Now, if the sample's compromised, the results are compromised, and so is patient care. Think back to what we know about microbes just even at this point. Some require oxygen, some are damaged by exposure, and some grow slowly. So, how the specimen is handled matters extremely or a lot. Okay, think about this. If a specimen meant for anaerobic culture is exposed to air too long, for example, what happens to accuracy of the results? Is it possible that we could lose organisms? We could lose what the real source bacterium is? Yes or no? What do you guys think? Yes. We lose the true reason on why our patients are on our tables in the first place, possibly due to oxidation. Exactly. This is why we're so responsible for maintaining sterility, supporting correct collection, ensuring that we have immediate handoff once the surgeon gives us permission to pass the specimen off. Communicating where the specimen came from, we're writing it down, we're trusting, we're verifying, and we're communicating. All this information directly affects how it's going to be interpreted. And at the end of the day, the best care that we can give for our patient. All right. We know that the midterm is coming up. Okay. This is just a self check. Okay. Do not stress out. I want you to choose one organism from your reading, either Staphylococcus aureus or E. coli. Without looking at your notes, this is all just for you. Okay. Imagine explaining to a classmate how that organism causes an infection from start to finish based on everything you know from weeks 1 through weeks 4. Now, I know it's a lot of chapters, but remember putting them in a story format. In your head, I want you to start the story with where the organism lives comfortably, then move to the growth. As you're thinking, notice what you're naturally connecting, how it grows, how it changes genetically, how it moves from environment to host. This is everything we've gone through so far. This is how we start that integration. Now, drop one word in the chat that represents the first step in your organism story, depending on what you picked, whether you picked Staphylococcus aureus or E. coli, Escherichia coli. Remember, there's no wrong answers. It's just trying to, I love it. Gut. I like that one. So you're looking at Escherichia coli. Haha. Cut, Staphylococcus aureus. You see how that starts to kind of come together just based on how you're building your story, how you're connecting the different um, pathogens. Okay. And by just what you're saying, I'm like, oh, this is the one they're thinking about. And this is how you get comfortable with the subject matter. There's going to be some pathogens we're going to be talking about to the end of microbiology. These are two of them, Staphylococcus aureus and Escherichia coli. We look at Staphylococcus pyogenes and a couple others that repeat because they affect more than one system. Okay? And if you got stuck in one part of the story, that's okay. That's just kind of a signal to, okay, let me just hone in a little bit more on this or that. The midterm is asking you, can you explain this relationship? Can you list the facts? Believe it or not, that is what you just practiced, even with that small, quick scenario. Now, as you guys are thinking to yourselves, which part of the story felt the strongest for you? Growth, genetics, transmission. You don't have to respond, but as you're building that story based on the pathogen you chose, believe it or not, that is where confidence already lives. Because you're just like, this is what I already kind of figured it out. I know this part, and now I can build on. As STs, we encounter microbes as isolated facts. We look at them from a lot of different processes as well. So our job is to kind of interrupt those particular processes because we see them in both ways. If you can tell the infection story clearly, you're thinking just like a microbiology professional. Okay. Now, there is a Kahoot. Let me give you guys. So I'll have to give you guys the updated Kahoot. It will be in the archive. Use it as an additional resource. Okay. Now, I know that you guys have a lot. Um, Make sure you are able to kind of just go back through Quizlets, your poll questions, your notes. If there's something in the archives that you're like, I wasn't really sure, let me know. Okay. You have also your audio overviews, your video overviews, depending on the week. Tried to kind of mix it up so it wasn't just all the same. And you guys have each other. Sometimes a peer can explain it maybe just a little bit better than I can. And again, I am always here. So you never have to worry because you're not in this alone. I get it. Microbe is a very dense course. And so I'm trying to break it down to a point where you feel comfortable and confident going into this upcoming midterm and even just this week. Okay. Now, this week is all about learning how growth depends on environment, how genetics accelerate risk, how transmissions adapt when conditions change. As we get into next week in midterms, all of this is very important. It all matters. Now, for those of you that are watching the playback, how might the AIMS test influence the development of new medical products and treatment protocols? Hint, hint, you may want to make sure you read up on that. How can we, as surgical techs, use our knowledge of mutagens to enhance patient safety in the operating room? And what steps can our surgical teams take to minimize exposure to known mutagens like ethylene oxide and ionizing radiation? You guys, I want you guys to continue to stay engaged. I'm going to still be here if you guys do have more questions. I will be completing your professionalism scores. You guys will start seeing those the beginning or the top of like Monday, Tuesday. I'm going to try to get them done for both courses. Wednesday, the latest, but you'll start to have those. With that, what questions do you have for me? No question. I do see a question. Let me scroll up. So, can you please explain what a competent cells are? Okay. So let me see if I can get my good breakdown, my analogy. Now, competent cells are bacterial cells that are able to take up free DNA from their environment. So, like, let's say there's just environment that's kind of naked, is a term we kind of use. They'll be like, okay, I'm gonna go ahead and grab that. And then what they do is they kind of incorporate it into their own genome. So that's where they get the term competence because they can kind of try to think of a way absorb that DNA and make it a part of them. Trying to think of a better example. Okay. You have, hopefully this doesn't sound too crazy. You have superpower, right? And you see someone that can change dirt into water. I don't know. And you're like, okay, I want to be able to do that same thing. So they're able to kind of go in and grab that DNA from that person that's able to take that particular skill and make it a part of them. So now they're able to kind of do the same thing. I don't know if that was a good analogy. Um okay, cuz I was like, I don't know, I was trying to think of something that was like that kind of makes sense. Okay. Did that make sense for everyone else too? I hope. Okay. Um any other questions? And that was a good one, by the way. Thank you. Okay, so if there are no questions, you guys, please have a wonderful rest of your evening. Be safe this weekend, and I do look forward to seeing everyone who can attend next week's live session. I'll still be on for anyone that has any additional questions, but if you do not, this is where I bid you adieu. Good night, everybody.